Let me tell you something most people don't realize. The ER is not first come, first serve. It's worst problems first. And that means two people can walk in at the same time. One gets rushed back immediately, and the other waits 6 hours. So today I'm going to tell you what ER staff takes seriously the second you say it, and what usually isn't an emergency, even if it feels scary. And trust me, this isn't about judging anyone, it's about keeping you alive. The ER works off triage. Triage means who is most likely to die first. So the question is never who got here first. The question is who needs treatment right now in the next 5 minutes or they could crash. So let's break it down. Here are some examples of what we take seriously immediately. Chest pain with sweating or shortness of breath. If someone says, I have chest pressure, they're sweaty, pale, short of breath, or clutching their chest, that person is getting an EKG immediately, which can't be done in the waiting room, obviously, because we're thinking that person is having a heart attack until proven otherwise. And no, you don't always have to be old to fall in that category. Stroke symptoms. If someone has facial droop, slurred speech, one-sided weakness, confusion, or sudden vision changes, that's an emergency, because stroke treatments are actually time sensitive. Every minute matters, and we actually use the term time is tissue. Trouble breathing. If you're struggling to speak full sentences, using your neck muscles to breathe. Wheezing badly, or your oxygen is low, you're not sitting in the waiting room like everybody else. That could be an asthma attack, pneumonia, blood clots in your lungs, heart failure. Could be a lot of dangerous things that we have to rule out. Another good one, severe allergic reactions or throat swelling. If you tell us my throat feels like it's closing, you're going straight back because anaphylaxis can turn into airway closure very fast. We see it all the time. And just by the way, if you have an EpiPen and you're allergic to something, use it. GI bleeds, vomiting blood, or black stool. If someone says they're throwing up blood or their stool is black like tar, that's a major red flag. Because internal bleeding is not something that you wait out. It gets bad fast. If someone has really bad belly pain with fever, vomiting, or guarding, we're thinking appendicitis, gallbladder infection, bowel obstruction, pancreatitis. Urgent care can't fully work that up, and those people might need surgery. Not something that they should wait for. If you hit your head and now you're confused, vomiting, passing out, or on blood thinners, that's serious, not someone who should be waiting in a waiting room. We're thinking brain bleed, which is really life or death, right? If someone says they feel faint, they're pale, clammy, their blood pressure is low, that's concerning. That could be bleeding, dehydration, infection, heart issues, many, many things, all of which have to be ruled out. Believe it or not, a big one is, I feel like I'm going to die. That symptom, that gut feeling symptom, that's real. When someone looks sick and says something is really, really wrong, we listen. Because sometimes the body and brain knows something before the numbers show it. Now, importantly, what people think is an emergency, but usually isn't. Chronic pain for months. If you've had back pain for 8 months, that's not an ER emergency. Not because it doesn't matter, but because the ER is designed for life threats, not long-term management. And the ER cannot and is not meant to fix chronic problems in one visit. Mild cold symptoms. If you have a runny nose, sore throat, body aches, and you feel miserable, that's usually urgent care or primary care. Unless you have severe difficulty breathing, chest pain, or a dangerously high fever, and dangerously high meaning over 104.0, then we're worried. Side note, if you come into the hospital or you go to see a primary care or urgent care and you tell them that, oh, I have a fever, and you can't give them a number, then you really don't have a fever. A fever is defined clinically by a specific number above a certain threshold. And if you just say, no, I feel warm, that doesn't really qualify. Sorry. A very common one is a slightly high blood pressure reading. This one is so common. People come in panicking because their blood pressure is 160/90. That's not an emergency by itself, right? In a vacuum, that's not an emergency. Blood pressures in the ER are almost always high because the person's already stressed, in pain, anxious, and because they're in the ER, so automatically the blood pressures are going to be much higher. Now, if it's high blood pressure plus chest pain, stroke symptoms, confusion, or vision loss, completely different story, right? Again, a fever. A fever alone isn't an emergency. The question is, how do you look? If you're alert, drinking fluids, and stable, probably can get away with going to urgent care. If you're confused, severely dehydrated, or short of breath, that probably belongs in the ER. Oh, I love when patients come in and say, I need a CT scan to be safe. A lot of people come in saying, I just want a scan just to check. The ER doesn't scan for reassurance. That's not a diagnosis or something that I can document properly. We scan when symptoms suggest something dangerous. Because scans have risks too, right? They're not all completely 100% safe. They all have side effects and risks, like radiation, contrast reactions, and false positives. Those are real. Minor cuts and minor injuries. I love this one. If the bleeding stops, the wound is small, and you're stable, you probably can go to urgent care. Unless it's deep, gaping on the face where you probably need plastic surgery or you can't feel the area. A mentor once told me regarding bleeding and cuts, anything will stop bleeding with enough pressure and enough time, for the most part. Last thing, what gets you seen faster without cheating? Looking sick actually matters. This is the truth. We treat what we see. If you're pale, sweaty, struggling to breathe, confused, or unable to sit upright, you will get taken seriously fast. You don't look well. And those patients often have the worst outcomes. Vital signs actually matter more than your story. We like to use objective information. We do take your story and what's going on into account, but vital signs are vital for a reason. Your blood pressure, heart rate, oxygen, and temperature decide a lot. You could say, I feel fine, but if your oxygen is 86, you're going back. And just to know, certain words trigger immediate actions. Trigger symptoms in the ER are something like chest pressure, shortness of breath, one-sided weakness, passing out, vomiting blood, black stool, pregnant and bleeding, worst headache of my life, sudden vision loss. Those are things that once we hear those, an alarm goes off and we're like, okay, something has to go on. These phrases get immediate attention because they correlate with serious emergencies. So now let's cover things that people say that actually slow them down. I Googled it and I know it's serious. Google doesn't help triage. It actually just makes you anxious, which will spike your blood pressure and bring us back into that loop that we were talking about before. And anxiety symptoms can mimic real emergencies. I'm here because I want antibiotics. Not an emergency. And if you demand antibiotics for a viral illness, you're basically telling the ER that you don't need an ER really. I'm not leaving until I get an MRI. MRIs are not ER tests most of the time. If you need an MRI, it usually means you need a specialist workup, not an emergency workup. MRIs are really good to rule out strokes and really should only be ordered in very, very, very small contexts in the ER. 99% of the time, we're not ordering an MRI. This one always gets me. I'm a 10 out of 10 pain. I'm going to be honest, everyone says that. Pain matters, but we don't triage based on pain number. It's subjective. We triage based on life threat. You can be a 10 out of 10 pain from a kidney stone, and someone with a heart attack can be sitting there calm. Pain is important, don't get me wrong, but it's very subjective, right? And so if I walk up to a patient and I see that they're sitting there comfortably on their phone texting or, chatting, playing Candy Crush or what have you, and they're telling me, yeah, I'm at a 10 out of 10. Not really a 10 out of 10 probably, right? 10 out of 10 pain means it's the worst pain you've ever felt in your life. You should be on the floor writhing and screaming and jumping out of your skin. And if you tell me that it's because you have a high pain threshold, then you're not really experiencing a 10 out of 10. Again, worst pain of your life. That is not subjective, that's objective. The worst pain in your life means that you should not be able to handle it. And finally, I thought it was important to cover this. The biggest myth about the ER. The ER is not a place where we diagnose every symptom instantly. The ER is a place where we answer one question. Is this going to kill you today? If the answer is no, we stabilize you and send you right to the next step. And that's not neglect, that's literally how emergency medicine works. If it's not going to kill you, we refer out, we send you home, what have you, you follow up with your PCP. We worry about what's going to kill you right now, immediately. So if you take one thing from this video, it's this. If you have symptoms involving the brain, heart, lungs, or severe bleeding, don't wait. But if it's chronic, mild, or something that's been stable for weeks, urgent care or primary care is usually the better move. If you want, I can make a part 2 on the most common symptoms people ignore that actually end up being serious. Comment one topic you want next, and I'll cover it.